My name is Alex Enriquez. I talk about acetazolamide in lithium-induced nephrogenic diabetes insipidus. Definition: diabetes insipidus is an abnormal disorder that causes an imbalance of fluids in the body. This imbalance makes you very thirsty if you had something to drink. It also makes you produce large amounts of urine. There is no cure for diabetes insipidus, but treatment can relieve thirsty and decrease urine output.
Diabetes mellitus has to do with elevated glucose, which, if it's elevated for most of the time during the day and night, will cause excessive urination. But then the diabetes insipidus is related to antidiuretic hormone deficiency, and that usually doesn't just hit people without a reason. There are situations when the MRI is abnormal with large cysts of craniopharyngiomas, when diabetes insipidus is going to be part of their presentation, meaning they're going to put out large amount of urine that looks dilute and they're going to feel thirsty all the time. But most of the time when diabetes insipidus happens, we know that surgery was performed, and usually it's a transient condition. So they're very different, but they have to be differentiated from each other because there are people with glucose problems who can also develop diabetes insipidus, and that's why endocrinologists exist, to kind of tease out these details.
Applications in the medicine: to reduce lithium-induced nephrogenic diabetes insipidus. Patients with bipolar disorder are treated with thiazide and amiloride, which are thought to induce antidiuresis by a compensatory increase in prourine uptake in proximal tubules. However, thiazides induce antidiuresis and alkalinizate the urine in the lithium and the misliking the sodium chloride cotransporter, suggesting that inhibition of carbonic anhydrase confers the beneficial thiazide effect.
How common is diabetes insipidus after surgery?
How common? Again, it depends on the type of tumor. So there is a specific type of tumor called craniopharyngiomas where diabetes insipidus can be very common, sometimes occurring before surgery or after surgery. And these tumors are typically large and can actually affect the back portion of the pituitary, rendering these patients in terms of a reduction in production of a specific hormone called vasopressin, which is why diabetes insipidus can develop. So in these types of patients, one has to be very careful and look out for diabetes insipidus after surgery. There are also other types of tumors like the big tumors that can also, after surgery, can cause diabetes insipidus. Generally, these are that when they occur, they are transient. They come and they go, and usually within the first 24, 48 hours, and then they get better over time. But again, it requires close vigilance for these types of patients to avoid patients from getting dehydration quickly.
Pros and cons. Pros: the clinical use drug acetazolamide attenuates lithium-induced down-regulation of AQP2 in MPK-C-D cells. Acetazolamide shows an improved overall electrolyte balance over thiazide amiloride. The antidiuretic effect of acetazolamide coincides with a lower GFR and reduced prostaglandin E2 release. Cons: dehydration, electrolyte imbalance.
Welcome back. Today we'll talk about diabetic insipidus. Diabetic insipidus refers to ineffective antidiuretic hormone, which results in inability to concentrate urine. ADH is secreted from the hypothalamus, so if the secretion is decreased, we call this central diabetic insipidus. And it works in the kidneys, so if the receptors are defective in the kidneys, we call this nephrogenic diabetic insipidus. The cause for central diabetic insipidus is basically anything that can damage the brain and decrease the secretion of ADH. The diagnosis is basically made by imaging studies where we see damaged brain, or by administering ADH and reversing the pathophysiology of central diabetic insipidus. In other words, if administration of ADH results in concentrated urine, this is the central type. The treatment is ADH analogs and hydration. Nephrogenic type is caused by damage to the receptor of ADH, which can be caused by hereditary receptor mutation or medications such as lithium. The diagnosis of nephrogenic type is made when the administration of ADH does not result in urine concentration. The treatment of the nephrogenic type is a little bit tricky, so I'm going to try explaining each medication as we go on so you can memorize them better. Thiazides are used because even though they are diuretics, they cause concentrated urine. NSAIDs are used because they break prostaglandin, which normally breaks ADH. So NSAIDs salvage whatever ADH we have left. Amiloride is especially effective in lithium-induced diabetic insipidus. And it doesn't hurt to give hydration and salt restriction. And here's a small quiz for you. So how do we conduct water deprivation test? And here's the answer. Alright guys, that's everything I've got. Hopefully I made this easier for you. Thanks a ton for watching, and I'll see you guys later.
Issue applied in Ecuador. According to the World Health Organization, in the world there are more than 347 million people with diabetes, and it's becoming a global epidemic related to the rapid rise in overweight, obesity, and physical inactivity. Diabetes is tested for become the seventh leading cause of death in the world by 2030.
Hello viewers, welcome to my channel. This topic is diabetes insipidus. Now, diabetes insipidus is not related to diabetes mellitus type 1 or type 2. And it is a condition characterized by large amounts of urine and increased thirst. And the amount of urine produced can be nearly 20 liters per day. And the reduction of fluids has a little effect on the concentration of the urine. Complications may include dehydration and seizures. And it's caused by the problems related to the antidiuretic hormone, which is known as ADH, or its receptor, and causes frequent urination. Now, there are four types of diabetes insipidus. Number one is central diabetes insipidus. Number two is nephrogenic diabetes insipidus, and number four is dipsogenic diabetes insipidus, and number four is gestational diabetes insipidus. Now, the most common symptom of diabetes insipidus is frequent urination. And the diagnosis of this condition is based on the series of tests, for example, urinalysis and fluid deprivation test. Now, the treatment for the diabetes insipidus depends on the type of diabetes insipidus, and it can lead to chronic kidney disease, and it's most common cause of kidney failure. Now, the treatment involves like drinking sufficient fluids to prevent dehydration, and other treatments depend on the type. And in the central and the gestational disease treated with is with desmopressin, So desmopressin, So, and nephrogenic disease may be treated by addressing the underlying cause, or the use of thiazide or aspirin or ibuprofen. Thank you very much for watching this video. If you need more information, you can visit our website www.diseasesandtreatment.com, and please do not forget to subscribe to this channel for more informative videos every day. Thank you and goodbye.
In conclusion, our studies reveal that acetazolamide attenuates development of Lithium-Induced to the same extent as thiazide amiloride, but in contrast to acetazolamide or thiazide amiloride-treated patients developed hyponatremia, hyperkalemia, and metabolic acidosis.
He is 2 years, 9 months old. We've travelled quite a little journey so far. Luca has a nephrogenic diabetes insipidus. It is a kidney condition. It's often mistaken for a sort of normal diabetes, sugar diabetes mellitus. It's only the same in that they wee a lot, so he urinates a lot more than what he drinks, basically. So at 3 weeks old, he presented with fever. And we kind of think fever is just okay, we all maybe struggle with things. And at that point, we thought to go back to the pediatrician that was at his birth and delivery. And she then admitted him. And she did the rigorous testing that identified that his sodium was extremely high and he was literally in dehydration. The trick though was his initial diagnosis, which actually was the accurate diagnosis, but then we had to revisit a couple of times. The real defining moment for his diagnosis was through a water deprivation test. But it was the only way we were going to really understand why he wasn't responding to medication and what medication he really needed. And I would say that was probably the hardest day in his life. It was definitely the hardest day of my life. There's no doubt about it. You know that your baby needs food and water and you can't give it to him. I know that it is a rare condition, there's no doubt about it. There are 3 unidentified families that we've been put in contact in South Africa. There is one other family who has a 6-year-old, so they've been a great family for support because they've kind of given us a long-term kind of idea of what to expect in terms of quality of life. The support of other families, I think, is integral. And to know that someone understands your journey is huge. Our commitment to rare diseases has been to support where we can. To be able to, if we can offer hope to other families, in terms of the medical teams, the doctors, who's out there, who understands these conditions. If we can just give back a little bit of what they gave back to us in those beginning stages. I remember the day that he received his rare. We're there to create awareness, to get this project off its feet and know that other kiddies can have that same symbol of hope and encouragement of a community that cares, that really does care. There's no doubt with rare diseases, South Africa is a family. They really are.
Thanks so much.